My name is I'm a doctor at Neonatal Resuscitation Hospital, and I'm delighted to be the moderator for today. With me is a panel of experts from different health facilities, and I would like to invite each one of them to briefly introduce themselves to the audience. I'll start with Dr. Anita.
Good afternoon, everyone, and you're welcome to today's session on a very important subject. By the name Dr. Anita Senhonza. I'm a pediatrician and neonatology fellow. I work at the Neonatal Specialized Women and Neonatal Hospital. Hope we learn together today. Thank you.
Good afternoon. Good afternoon, everyone. I hope you're well. My name is Claire Anisigwe. I'm a nurse, Neonatal Resuscitation program. I'm happy to take you through neonatal resuscitation today. Hope we'll be able to learn a lot and unlearn. Thank you.
Good afternoon, everyone. My name is Albert Okanya. So I work in Guru General Hospital as a nurse, and I'm delighted to be sharing today with you about our very vital topic, acts of God. I'll be happy to learn together with you today. Thank you.
Good afternoon, everyone. I'm Dr. Paul Marchen, a pediatrician from Gulu Regional Referral Hospital. I will be taking you through the chat questions, and we hope to learn together. Thank you.
Yeah, hello. Good afternoon, online team. I'm Dr. Latif Emmanuel. I'm a pediatric, the resident in pediatrics and child health at Gulu University. Currently doing my rotation at Regional Referral Hospital. I'm also a student representative in the Faculty of Medicine Students Association. I'm delighted to be here. My role will be to thank you for the first presentation.
Thank you all to our online team. Kindly ensure your microphones remain muted, and feel free to engage in the chat with any comments. Dr. Palmer will be addressing the key questions that will be raised in the chat, and to also help us align our discussion with your needs, I will invite you to the participants to tell us what their expectations are for this session. You can raise up your hand or you can write in the chat. Yes, Dr. Alex Ndelema, may I kindly know what your expectations are this afternoon? As people are voicing out their expectations, pre-test questions have been launched on your screen. Kindly attend to them.
Okay, thank you so much, Dr. Betty. My expectations today, hope I'm audible.
Yes, you are.
Am I audible? Okay, so my expectations today for the discussants to help us understand more about the neonatal resuscitation, its indications, and how it's done. Yes, basically. Thank you so much.
Thank you. Anyone else? Meanwhile, as you are attempting pre-test questions. I still invite more expectations. I'll choose some of the participants to kindly tell us what they expect to learn this afternoon. Dr. Dorothy Nandata, could you kindly unmute and tell us what you expect to learn this afternoon?
Thank you, Dr. Betty, for the opportunity given. Well, I would not differ so much from Dr. Nderema. However, I would like emphasis on the steps taken in resuscitating a neonate and what measures can be taken to save neonates in that golden minutes that we always talk about. Thank you.
Thank you. Hope that has been noted down in our experts. And yes, Ms. Gini, kindly unmute and voice out your expectations. Ms. Gini. Yes, Mr. Daniel.
Hello. Thank you very much, Dr. Betty. I've just been given permission to unmute now. I'm expecting to hear much emphasis on post-resuscitation care, because usually we resuscitate and just move on. So that is what I'm expecting to hear much more. Thank you.
All right, that has been noted down. We had one more hand. That was Mr. Daniel, if you're still there. Okay, to kick us off, I invite Dr. Nadine to take us through the case presentation.
Yeah, thank you so much, moderator. Once again, I'm Dr. Latim Emmanuel. I'm a resident in pediatrics and child health from Ulu University, currently doing my rotation at the regional referral hospital. So I'll take you through the case. So prematurity complications and birth asphyxia are the leading causes of mortality among babies in both at national level and internationally, and the majority of neonates who require resuscitation actually come from these two. So the case I'm going to present is of an extreme preterm that we managed last month. So it was extreme preterm neonate who was delivered on the 23rd of June 2025 at 7:49 a.m. by SBD at 22 weeks of amenorrhea by death, and Ballard score revealed a gestational age of 24 weeks, but averagely we thought of between 24 to 26. The 39-year-old para 7+2 mother who came in second stage of labor with cord prolapse and breech presentation. The birth weight was 950 grams. APGAR score at 1 minute was 4. At 5 minutes was 5, at 10 minutes was 6. There was no documentation of any resuscitation done at the time in the labor room, whether stimulation, warming the baby, suctioning, bag mask ventilation, or CPR. But it was documented that this baby was put on oxygen. It seems this baby had spontaneous breathing at the time. Vitamin K was given at 0.5 milligrams start. Baby was put under radiant warmer in the labor room and also on free flow oxygen at 1 liter per minute, awaiting transfer to the NICU. So it was after about 1 hour that we received the baby in our preterm section in the NICU with vitals of hypoxia at 86% on room air, with a borderline pulse rate of 100 beats per minute, normal respiratory rate of 50 per minute, was hypothermic at 35.6 degrees Celsius. Remember, this baby was already under radiant warmer in the labor room. The random blood sugar was normal at 4.4 millimoles per liter. So the interventions at the time, there was no need for resuscitation still. So the baby was put on oxygen by continuous positive airway pressure, CPAP at 3 liters per minute, and the oxygen saturation had increased to 100%. The pulse rate improved to 133 beats per minute, respiratory rate of 51 per minute. So later, baby was reviewed and noted the extreme low birth weight, extreme premature transferred from the maternity with persistent difficulty in breathing and bluish discoloration, as well as swelling of the lower limbs. There was no history of fever or convulsions. Baby had not yet started meconium. Had not yet passed meconium. Had not yet passed urine. Had not yet breastfed. Given the state of the baby, review of systems was unremarkable. So the mother reported that she had had labor pains that started the day prior. There was no history of premature rupture of membranes. She tested positive for malaria 3 days prior from the health center, where she was given Coartem, which she had completed the day before she came for the labor. There was no history of prenatal steroid administration. She attended ANC only twice, starting at 14 weeks of gestation, tested negative for HIV and syphilis. She was given Limatinics but didn't receive Fancida. She had no documentation of booking blood pressure or other essential things. The other siblings are all fine. She reports 2 previous miscarriages, all were in the first trimester. The causes were not known. So on examination, the baby was sick looking, was lying in an incubator. On arrival from the maternity, we placed this baby in the incubator. On CPAP, extremely small, in moderate respiratory distress, lower limbs all cyanose from the upper thighs to the lower limbs to the feet and soles, also with mild swelling. However, the upper part of the body is pink with no dysmorphic features. There was no jaundice, no pallor, no dehydration. Was quite hypothermic at 35.7, normal respiratory rate of 56 per minute, pulse rate normal at 136 beats per minute, normal oxygen saturation and CPAP, as well as normal random sugar. Respiratory findings had obvious features of respiratory distress as listed. With chest drawing, there was grunting audible with on auscultation, subcostal recession, intercostal recession, and the Silverman Anderson score, or the respiratory score was 5/10. The chest was clear. The CVS findings were normal. Apart from the peripheral cyanosis, there was no central cyanosis. Axons were normal, and all the peripheral pulses were present and synchronous. The CNS findings, the fontanelles were all normal. Primitive reflexes were all weak. The suckling reflex, moral, grasp. There were no There were no localizing signs, had a weak cry. Abdominal findings were normal. So our diagnosis at the time was extreme prematurity with extreme low birth weight, with moderate to severe respiratory distress syndrome, hypothermia, at risk of multiple prematurity complications, including hypoglycemia, hypothermia, necrotizing enterocolitis, etc. So extreme prematurity in view of being born at 22 weeks gestation by death and 24 weeks by balance score. And this corresponds to the World Health Organization classification of prematurity. And less than 28 weeks gestation is defined as extreme prematurity. Extreme low birth weight, because this baby had a weight of less than 1 kg, which also corresponds with the WHO classification by birth weight. Moderate to severe respiratory distress syndrome, because in that history there was persistent difficulty in breathing from the labor's room, and even at the time of review, and the respiratory findings of respiratory distress and the Silverman score of 5/10. Hypothermia because of the low temperatures. So our plan at that time was to keep the baby in the NICU, to keep in the incubator, keep on bubble CPAP at 3 liters per minute, meal per host for 48 to 72 hours. Because this is an extreme preterm, it's already having severe RRDS, the risk of necrotizing enterocolitis is high, so that's why we put on meal per host. We gave a loading dose of IV caffeine, as well as of 20 milligrams per kg start, and a maintenance dose of 5 milligrams per kg twice a day for 2 weeks. We put this baby on IV dextrose 5% infusion and 3 meals per hour for 24 hours. Since dextrose 10% is not recommended for this category of patients. We gave a lot, we put on ampicillin at 50 milligrams per kg twice a day, as well as low-dose gentamicin 3 milligrams per kg once a day to prevent sepsis in this baby, and also to monitor the vitals every 2 hours. So maybe something to add, this baby was transferred from the maternity on free flow oxygen. So the following day in the morning of 10:20 a.m., it was noted that the baby had deteriorated while in the incubator and CPAP, was gasping, was very apneic, there was no spontaneous breathing, was very cyanous, floppy, with no cry. The pulse rate was very low at 68 beats per minute, so was bradycardic, less than 100 beats per minute. Was very hypoxic at 53% and hypothermic at 34.7. So the baby was removed from the incubator and placed on the radiant warmer. Heart was stimulated, but there was no response. There were no obvious secretions in the mouth or in the nostrils, so there was no need for suctioning. But because the pulse rate was low and the baby was very apneic, we started valve mask ventilation, so positive pressure ventilation at a rate of 30 to 40 breaths per minute. Also gave IV dextrose 5%, 2 meals bolus, IV adrenaline 0.1 milligrams given at a certain point. A loading dose of caffeine was given to stimulate breathing. And then an infusion was maintained in IV dextrose 5%. So this baby was resuscitated for quite a long time, and despite all this, it was noted that the baby's vitals were only improving on resuscitation and dropping immediately post-bagging. So the baby was maintained on oxygen and maintained on IV dextrose 5%. It was at about 40 minutes after that the baby was noted to be unresponsive with vitals all unaffected, no cardiac activity. So resuscitation was initiated again by positive pressure ventilation, stop bag mask ventilation, and CPR 3 compressions to 100, and 3 mils of IV dextrose 5% given as the bolus. It was 25 minutes later that the baby, despite all efforts at resuscitation, the baby, there was no response. So the baby was confirmed dead with the cause of death being extreme prematurity, extreme low birth weight, with severe respiratory distress syndrome, with severe respiratory failure, other contributors being hypothermia. Yeah. So thank you so much. This is the case that I presented, and reactions will come, which I'll hear comments on in reference to what will be presented by the rest of the experts, comparing the key emphasis here is on the immediate care of the newborn, resuscitation, and then post-resuscitation care, which will see whether did we do the right thing or not. But being in our area of Guru Regional Referral, where we have no resource setting, we have limitations. We did what we could in regards to the management we could give, the limitations we have as a unit. We thought maybe this baby would benefit from a neonatal ventilator, but still 24 to 26 weeks is still very debatable whether this baby would benefit. Remember, at 24 weeks, the lungs are still at the canalicular stage of embryonic development. And then also the fact that we don't have surfactant in our setting, because despite all efforts at resuscitation, this baby is still under surfactant.
Thank you so much, Dr. Latin, for that informative and relevant discussion today. I will give a chance to 1 or 2 participants to give their reactions to the guest. You may raise up your hand if you wish to react to the guest presentation. If there is none, allow me to invite Mr. Okanya Alba to take us through the preparation for resuscitation.
Thank you. Once again, my name is Alba Dokanya. As we continue with our discussion, allow me to take you through the preparation for resuscitation. So first of all, let's try to understand what neonatal resuscitation is. So we have defined it as a set of established and standardized measures carried out to imitate, attain, or support breathing in a newborn and a baby with breathing difficulties immediately after birth or within the first 28 days of life. So, as we proceed to our preparation, I think the key thing that I would wish us to take home from this specific part of the discussion is the importance of readiness. Because imagine you have received this kind of mother delivered for you this preterm, or you're being transferred to a preterm and you're not prepared. Like literally, there is nothing much you can do if you're not prepared. Because preparation alone might cost this baby's life in the process. You might be prepared, and by the time you prepare, it might be too late. So effective and timely preparation is really very important. And we are saying this is simply preparing for neonatal resuscitation, or it involves getting ready to carry out the procedure of neonatal resuscitation. So let's look at our key requirements. I know this is not 100% everything we shall need, but these are major things we shall need. One, we have said we shall need a radiant warmer turned on or a warm environment. So sometimes I believe there are some facilities that may lack a radiant warmer. So you should also be able to create a warm environment for resuscitating this baby. Two, we shall need dry, warm clothing and a cape. We know the role of this clothing, meaning if you need to require to deliver this baby, there is first clothing to use to dry up the baby's body. Make sure you remove those ones and replace with the dry one to use for resuscitating our baby, because we don't want our baby to succumb to hypothermia during the process of resuscitation. Three, let's talk about suctioning devices. And as we must all be aware by now, penguin suckers are most recommended compared to suctioning machines. So make sure you always have this penguin sucker. Bulk syringes are discouraged because of the fact that it is hard to know if it's clean inside. So penguin suckers that are transparent help you to be assured that you have your clean penguin sucker. Then the fourth one, we have armed bag and mask. This should be of an appropriate size. I believe my seniors will give us more light on specifically what the sizes look like, and also the mask, the specific ones that are recommended for neonates. Then we also need to prepare for bubble CPAP. We should have it set up for those that are having CPAP machines. It is the best. Then for those that use improvisation, like even my facility is partly improvised because what we have is not enough to cover our demand. Then oxygen source and also tubings. These are also very key. There are times when you might even connect. There are some masks that allow you, some handbags that allow you to connect oxygen during the process of resuscitation. Then the also tubing, this could also be a neonatal size. And we may note preterms use kind of more smaller size of neonatal tubing compared to term babies. So you should have appropriate size given the baby you have. Then we should have a pulsometer and a thermometer, or you may have a patient monitor. So this will help you should have this connected to the baby so that you'll be able to continuously monitor if your resuscitation is of use, if the baby is improving by vital signs. Then we also have the clock or a timer. This is one thing, but you can have either of the two. This will help you at least to understand the duration that you've taken in a specific time. And specifically, let's pay attention to the golden minute. This should help you know that you've started your ventilation within the 1 minute, our golden minute. Then gloves, also sterile cord cutter, specifically for those that will be receiving this baby right during delivery. Then a stethoscope, also for assessing our heartbeat and bilateral air entry into the lungs. Then we shall also need NVQ or orogastic tube and its accessories. Then we shall need a set for carrying out cannulation, because sometimes after oxygen resuscitation, we might also need to do resuscitation, where maybe we might need glucose, or sometimes we might need a volume expander. Then next we have syringes and IV fluids. Put in brackets dextrose 10%, but sometimes, like I've said, we might need a volume expander. And those are the accessories that will help us to. Then in more advanced settings or situations, we may need a laryngeal mask airway, or we might need intubation supplies, other intubation supplies to help us carry out the intubations. Now let's see the next slide. So this is still a continuation of our equipments. However, the ones we have here, I labeled them as post-resuscitation. This one we might need after the active airway ventilation. For example, we might need a glucometer to monitor all of this glucose level. So sometimes you might continue resuscitating, yet what is preventing your baby from picking up might be the fact that the baby is severely hypoglycemic. Then we may need an incubator or still a radiant warmer to keep this baby's temperature maintained within accepted ranges. Then we may need drugs. And the drugs we may usually need in some situations that my seniors will still elaborate more. We might need a epinephrine. I had also added there caffeine, then normal saline, and sometimes antibiotics might be initiated immediately after resuscitation, depending on the other factors. Then we may need devices like a monitor that we shall keep in place to continue monitoring this. Then we shall need documentation forms, because at least if we have not documented any of the things we shall be doing during our process of resuscitating, it will look like we have completely not done anything. So it's very key. Then as an expert, identifying units at risk and communication. This is also part of preparation. Mostly the labor suit or the delivery group, they should be able to understand that this mother has gone into labor prematurely, and as part of preparation should be able to inform either the person responsible for resuscitating this baby or informing the neonatal team to be ready to receive this baby. Then we have talked about other babies that will be at risk, and therefore necessary communication to be made, being those ones with meconium, staining, then babies like multiple gestation. Among others, we have those mothers who are PET mothers, those ones that are diabetic. Those are all babies that might need resuscitation. Therefore, appropriate communication should be made, the necessary teams to help during the resuscitation. Then the next point down, we're talking of identifying high-risk deliveries. I think that is covered within the upper one. Then communication to the team should be informed in case of a baby that will need that kind of procedure. Then also preparing equipment and personnel accordingly. So there is setting, then doing the procedure. So these are just a few things we might want to really keep in mind throughout this discussion. Have the team ready to help, one. Then two, pay attention to the airway, ensure the ventilation is effective. Then make sure you're doing appropriate test compression. My seniors will elaborate more on how you should compress the test. Then at least have someone who is well versed with resuscitation. We have one trained resuscitator. I believe one of these days, at least every facility has this kind of people. Then you review the golden minute concept. Make sure in your mind you prepare and receive this. Make sure you also know in your mind that within this golden minute, this is what I should have done for this given baby. Then this ventilation should always be initiated within 60 seconds, within the first minute, within the golden minute, in other words. Then go through your resuscitation algorithms, like the major common one I've seen in most facilities is that one of HBB, helping babies breathe, just to remind yourself what you need to do. Then on our other page, just that first line up that is likely to be instructed, we are looking at the steps we take during this process. So after you've received your baby, the most first thing you do is dry and stimulate. That will also be elaborated, then assess for need for resuscitation, then stimulate also where need to be, then ventilate where need to be, do chest compression where need to be, and medication where need to be. So in other words, it should be sort of the flow chart of that format. You don't start by giving, say for example, medications like epinephrine before you even done chest compression or before ventilation has come. So it should be systemic. Otherwise, it will be continuing ahead, but that will be a repetition because that's most of the information that my seniors will add on. So I beg to end here. Thank you all.
Thank you, Mr. Okanya, for that well elaborate presentation. Thank you again for reminding us of what we also prepare, what we also have, and the way for resuscitation. And right about now, I will invite Ms. Claire to take us through the neonatal resuscitation, the actual demonstration. If you have any other information, any questions, please get in the chat.
Good afternoon once again. Claire and Lucia with you. Going to take you through the presentation of babies born preterm. So those are the original assessments. I hope you attended the questions and you got everything right. So what is the purpose of newborn resuscitation? We need to understand why we need to resuscitate the babies, especially at birth, because the intrauterine life is different from the extrauterine life. So it's very important that sometimes we may come face to face with the babies who need support to transit fairly or effectively to extrauterine life. So one of the purposes of the neonatal resuscitation is we want to restore the normal respiratory and cardiac function of the baby, because the changes that happen in intrauterine are different from the extrauterine. So we need to support the baby with respiration with the respiratory function. Another purpose can be we want to prevent organ injury, especially for the babies who have had hypoxia. We need to be able to provide oxygen support right in time and prevent injury from hypoxia and ischemia. Another purpose that we need to understand is we want to prevent neonatal death and lifelong disability. Usually these babies, if the neonatal resuscitation at birth is not effective, we might discharge these babies, but what kind of life are they going to live after? So we need to ensure that we improve the life of these babies even after they've been discharged from the hospital. So what are the potential benefits of neonatal resuscitation training? We want to prevent at least 10% of all newborn death by immediate assessment and stimulation only. Just imagine a baby at birth only needs stimulation and you cannot be able to provide. So just by stimulating and knowing how to stimulate these babies, and be able to prevent 10% of all these newborn deaths that we are having that are contributing to neonatal mortality. Another factor is we want to prevent at least 20% of all these newborn deaths by basic, bag, and mask resuscitation. So it's very important for all the health workers who attend deliveries to have skills in this bag and mask resuscitation. How do you choose the right mask for a baby, for a preterm baby, for a term baby? You have the right equipment, the right bag to use. Then again, we want to reduce 38% of early neonatal mortality, at least in the first 7 days of life. That is still a very big percentage. So if we have the neonatal resuscitation skills, we are able to prevent all these deaths by just doing the right thing. So we are going to see exactly what happens, transition from the intrauterine life to extrauterine life. So usually the baby in intrauterine, the lungs are filled with fluid. So what happens at birth is when the baby breathes, the lungs, the fluid in the lung is replaced by air, and then the baby is able to start breathing. Then also when the cord is clamped, that means that the circulation is going to be cut off from the placenta, and baby is supposed to be independent and be able to breathe on their own. Another thing is at birth, the fluid in the belly is going to be absorbed, and air replaces completely the alveoli. So this pushes carbon dioxide to the alveoli to be exhaled, and then there's also oxygen that is emitted into the lungs. So air in the alveoli is able to cause the blood vessels in the lungs to dilate. That is the So sometimes babies have challenges with transiting very well. So we need to support them in this transition. So how can we know about the interaction in normal transition? So usually when there's abnormal transition, meaning that oxygen is going to be coupled to the organs, the minor organs like the liver and everything. So what happens when the oxygen is cut off? There's going to be accumulation of acid in the tissue. So this causes the oxygen supply in the tissues to reduce. It's going to reduce the oxygen saturation in blood. It's going to increase the oxygen. It's going to reduce the oxygen saturation in the blood, causing cyanosis and fever. Am I audible? So when the baby is faced with this difficulty transiting, they will go into a temporary survival reflex. So what happens is blood is going to be focused to the vital organs. When there is no intervention done, for example, if the baby is not born at this time, if there's no resuscitation done, it's still going to continue, the baby is going to still have persistent inadequate gas exchange. So what will happen with the baby is it will decrease the blood flow to the organs, consequently leading to organ damage. So the time you take to resuscitate babies is very important. So what are the clinical pictures that they will present when you've had challenges with transition? So X-ray and they are going to present with labor breathing because the fluid in the lung has failed to be reabsorbed, and meaning there's no clear gases exchange. So the babies are going to have presenting with granting respiration, they're going to have irregular breathing, they're going to have slow heart rate, even decreased muscle because of the reduced oxygen supply to the tissue. So all these we need to do. So we need to assess the clinical features and intervene according to how the baby presents. Thank you. So we also okay. Sorry about that. So let's go through the foundations of neonatal resuscitation. It's very important for health workers who attend to deliveries to have the key points in neonatal resuscitation. The most effective step in neonatal resuscitation is to ensure that you ventilate the baby's lungs, especially within the first 60 seconds. It's very important that you maintain the golden minute so that the baby is able to receive ventilation, especially if they are apnea, if they are not breathing. So resuscitation should proceed quickly, efficiently, without any interruption. So if you have the skills at your fingertips, you're able to effectively complete each step in the neonatal resuscitation program flow diagram, especially to ensure that every action has been done effectively. And another important key point is to ensure that you're working as a team and you have a strong leadership to ensure that everything is done perfectly well, and also to have effective communication to be able to handle all the critical issues that are happening at birth. Then next, please. So what happens, especially why are preterm babies at high risk of injury at birth? Preterm babies are at high risk of requiring resuscitation. First of all, because their vital organs, the lungs, the brain are still immature. So they usually need assistance to transit from intrauterine life to extrauterine life. So if you have all the supplies and equipment used, you're able to support them to transition effectively. So we need to ensure that we prevent heat loss by providing the right supplies, which we are going to see later, and also ensure that we provide we provide all the necessities like the drugs, the blood volume that we need to give them, and which are supposed to be calculated prior to birth. And ensure also the temperature in the room is within the normal ranges. What is recommended is the temperature should be kept between 23 to 25 degrees centigrade, especially in our theaters which have AC. We can advocate for having the AC switched off, especially prior to birth of these babies. So what can you do to decrease the risk of neurological injury in these preterm babies? The babies need to be handled gently. Ensure that you support the head of the baby with both hands and lift the baby gently, especially at birth. We have instances where the baby is just handled by legs or by hands, and that also affects, causes injury to their brain. So we need to emphasize safe handling of these babies at birth, because the care you provide at birth is ultimately going to affect the outcome of these babies. So the self-care of these preterm babies especially starts at birth. So what we provide at birth will definitely affect the life these babies are going to live. So avoid positioning the baby's legs higher than the head. So when you lift the legs higher than the head, you're going to increase venous return to the brain, which can increase the risk of intraventricular hemorrhage in these preterm babies. So we also need to avoid using high positive pressure ventilations or the continuous pressure for the CPAP that we use. What is recommended is for positive pressure ventilation, we have to maintain and start with low pressures at 20 to 25. And also CPAP, we need to start with low pressures of 5, which you are going to see. So for that positive pressure ventilation, we need to use an amp bag that has the pressures on top, so that you're able to keep in mind how much pressure you're using to ventilate the baby. So ensure that you have the best equipment for the baby, especially with the arm bag. Then also we need to use the pulse oximeters, because they help us to adjust the oxygen concentration and target range to be between 90 to 95, so that we do not cause retinopathy in prematurity, which is as a result of giving higher concentrations of oxygen to the babies once preterm. And also another important thing to do to prevent neurological injury to the preterm babies is to avoid giving rapid IV fluids infusions. So this sudden increase can increase the cerebral blood flow and also rupture the blood vessels in the brain, also putting the baby at high risk of IVH. So we are going to go through the NRP resuscitation algorithm. So this algorithm is it describes the steps that you take to resuscitate this baby effectively. So it is divided into blocks, including the initial assessment of the baby and birth. The first block is airway, which has to be emphasized in the first 60 seconds, which is 1 minute. So you make sure that the baby's airway is open and remain patent by providing a shoulder pad, especially for preterm babies who have soft and longer necks. Then the second block has the breathing, which emphasizes the use of positive pressure ventilation for the babies who are having apneas or who are gasping. Then the next block, which emphasizes the use of chest compressions, especially for the babies who have failed to have a rise in their heart rate above 60 beats per minute. And also the last block, which emphasizes the use of epinephrine, which is the recommended drug to use to resuscitate these babies. So for emphasis of time, today we are going to learn the neonatal resuscitation program essential skills, which contains the foundations of neonatal resuscitation, the anticipation and preparation, the initial steps, and also the positive pressure ventilation. So we shall stop that, and maybe next time we can go through the advanced resuscitation. Another thing we have to understand on this algorithm chart is that it has different blocks. So the hexagon block emphasize the assessment, the evaluation that you need to do on the baby. So once the birth happens, you're supposed to assess the baby. Is it a term baby? Is the baby having a good tone? Is the baby breathing? And then immediately when you do that quick assessment, which is the rapid assessment, then the rectangle blocks emphasize the interventions or the actions that you need. So once your assessment is done, you either go through the interventions as provided in the chart. So it's very important that all these charts are printed and put in your delivery room for easy references. Okay, next. So what are the NRP key behavioral skills? Usually, it's very important to have these skills as health providers, especially at birth. Sometimes we are called upon in delivery rooms to assist in high-risk deliveries. So what are the skills that you need to go with? First of all, you need to know your environment. This means is when you're called in the delivery room, you need to know where each equipment is. You need to know where in case you need help, maybe from the anesthesiologist, where you can find them. So it's very important that you see the environment and know where each equipment is placed in case you need it. Then use available information. This means that you're going to ask about any perinatal information, read the file, ask the midwife, especially the high risks that the mother could be having. Maybe the mother had cord prolapse, or maybe the mother is having PET, severe features. So all this information enables you to anticipate and plan and prepare for this baby. And then anticipate and plan skills will enable you to plan accordingly and prepare the right equipment. Imagine you're going to receive a preterm baby and you prepared the mask for a term baby. So that will delay you in providing the effective resuscitation for this preterm baby. So in anticipating and planning, you're able to know which exact equipment that you need for this particular baby. So clearly identify a team leader. So having a team leader will enable you to be able to ensure that all the critical areas are covered, will enable you to ensure that you're doing the right thing. You need someone to remind you whether you're doing the wrong thing, whether you're following the right steps. So having a team leader is very important during resuscitation. Then another skill that you need to have on your fingertips is communicating effectively. How are you communicating? NRP recommends having a closed loop communication, so you're able to avoid errors. Another skill that you need to have on your fingertips is to be able to delegate workload optimally, especially as different people we are good in different fields. So you ensure that you delegate someone who is good in positive pressure ventilation to handle that. Someone who is good in documenting to handle that, so that every information, every action that is done on the baby is very well documented, because it is going to be used especially in the NICU to be able to manage the baby. Then allocate attention wisely. You're able to know which particular point you need to emphasize on. For example, if the baby is born, you ensure that in first minute, you're able to ventilate the baby's lungs. Then also use available resources. We are still lacking some essential supplies, so use what is available at that particular time. Then be able to call for additional help in case you need to, and also maintain professional behavior among the team. So how can you anticipate and prepare for resuscitation? We need to also know these key points so that we are able to provide effective resuscitation. So first of all, be prepared. I emphasize preparation for resuscitation because it is going to enable you to remove the gaps in delay. Imagine you have to run to look for the handbag. Imagine you have to run to look for a mask. So when you prepared, meaning you have everything that you need for this baby. Identify high risk factors earlier enough so that you're able to know and support this baby from intrauterine life to extrauterine life to be able to transition very well. Then also you have to know that some newborn babies, sometimes we have elective cesarean sections, and you're sure the baby is going to breathe immediately, the baby is going to have a good tone, but for no apparent reason, the baby is going to need resuscitation. So just be prepared to resuscitate every baby at first. So you need also a qualified team with resuscitation skills to be able to identify any risks on the baby. So having knowledge and skills in resuscitation is very important. And NRP recommends that for every delivery, they should have a qualified or a health worker who has resuscitation skills and they are able to provide effective resuscitation as well. Then ensure that you have all the supplies that you're going to need for this baby to provide complete resuscitation. So what are the additional resources that you need to resuscitate a preterm baby? So in our setting, like I said earlier, we need to have skilled personnel, ensure that you have skills, you have the knowledge, you practice resuscitation, especially being involved in simulation drills to be able to know how to resuscitate a preterm baby. Then another important resource is having a polythene plastic bag. And NRP again recommends a food grade plastic bag, especially if you don't have the already sterile polythene bag. So this can also come in handy to maintain warmth for preterm babies, since they have a high risk of suffering from hypothermia. So we need to use the bags so that we minimize heat loss. Then another important equipment that we need to resuscitate preterm baby is having a servo-controlled radiant warmer. This is just different from a radiant warmer because you're able to maintain, to regulate the temperature of the baby compared with a radiant warmer. So you need to have a temperature sensor attached to the baby so that their temperature is easily regulated. Another equipment we need is having an oxygen blender. Preterm babies are better put on blended oxygen to avoid high risk of retinopathy, and ensure that you have a pulse oximeter, which will help you to guide the oxygen you're going to give to the baby. Also, you need a cardiac monitor, especially when you're going into advanced resuscitation, so that you're able to have effective, you're able to assess the baby's heart rate very effectively. Next. So how can you, during anticipation of neonatal resuscitation, when you're called to the delivery room, these are the major important questions that you need to ask. You are going to ask the OBGY what expected gestational age the mother is at. So this will help you to know if you're going to deliver a preterm baby or a term baby. And it's also very important to ask about the amniotic fluid so that you know if the baby has gone through longer period of hypoxia before they are born. And also, it's very important to know if there are any additional risk factors, especially if maybe the mother has bottom hemorrhage, maybe the mother has ruptured placenta. So all these risk factors enable you to plan accordingly. And also, what has been added on the newly updated NRFP is to know if there's going to be a umbilical cord management plan. So for big preterms or preterms which are like 35 weeks and above, as long as they are vigorous, they can also go through delayed cord clamping. Next. So what are the resuscitation team briefing? What did you need to discuss with the team going to resuscitate? We've already talked about this. You identify a team leader. You've already anticipated the potential complications, especially for a cord product. You're going to know that the baby might need volume expanders. So you need to plan early. You're going to delegate tasks. Choose who is going to document the scenarios, who is going to document all the actions that are going to take place. Determine what supplies and equipment will be needed. If you're going to need positive pressure ventilation, if this baby is likely going to need pressure PPV, ensure that you have the adequate arm bag that you're going to use. And then identify whom you're supposed to call in case you need additional help. So this is guides us on the quick equipment, NRP equipment check. We can have this printed out and put in a delivery room so you're able to know for warmth what equipment you need. So you need a preheated warmer. As long as you're preparing for the birth, ensure that you switch on your warmer so that it is preheated before the baby is born. You need a warm blanket. You need a plastic bag. This is very essential for the babies. And then also a transport incubator for transporting the baby from the delivery room to the NICU. So for clear airway, you're going to need a bulb syringe, which is a penguin. As the earlier presenter mentioned, we need a clear penguin stuffer compared to the bulb syringe. So this is very good in ensuring that you maintain infection prevention control measures. So this is highly recommended. And suction also comes on the clear airway because sometimes you need to provide advanced resuscitation. So a suction also comes in handy. For auscultation, you need a stethoscope, and then oxygenation, you need equipment to help you to give free flow, especially for babies who are term or who just have nasal flaring, and then pulse oximeter with a sensor to help you to ensure that you're giving the right oxygen. Next. So ventilate, you need, you have to set your flow meter at 10. You need an oxygen blender, you need PPV devices, the arm bag that is right for the babies. And then you need preterm face mask for preterm babies. You need feeding tubes, especially for babies are going to be on CPAP for longer periods. Then for intubation, you need the laryngoscope sets, which we are not going to go through at this time. Then medication, you need to know that you have access to epinephrine. And also the miscellaneous, you need a timer, clock, and gloves. So those are the different equipment that you need. We can see the neonatal arm bag that has the pressure gauge where you're able to see the pressure that you're using. We need to avoid giving high pressures because sometimes you're taken over by event and then you just press the arm bag with a lot of energy and you end up injuring the baby's lungs. So you need to work within the recommended pressures, which is 20 to 25. Next. So this is the NRP flowchart. So in the golden minute, we are emphasizing providing positive pressure ventilation within the first 60 seconds. So on the algorithm is that let's assume the baby has been delivered, birth has happened. So you do a very rapid assessment. You look at the baby as the surgeon is still holding the baby. You check if the baby is calm, if the baby is having a good tone. A baby who's having a good tone will be able to move their extremities. So you're able to notice the baby is having a good tone or not. Then you also check if the baby is breathing. A baby who's breathing will definitely be crying. So if the baby is, if all your questions are yes, that means the baby can stay with the mother, or you can continue with the initial steps of resuscitation and ongoing evaluation. If one of the questions is a no, that means the baby needs to be brought to the radiant warmer immediately, and you perform the initial steps of resuscitation, which are warming, drying, stimulating the baby, positioning the airway, and suctioning. We are going to look at those in details later. However, you see in the block, it has 1 minute. You're able to provide positive pressure ventilation for a baby who is having apnea. Apnea is when the baby is not breathing, or even gasping is ineffective breathing. So even that baby qualifies to get to benefit from positive pressure ventilation, or if their heart rate is below 100 beats per minute. So all those, you have to ensure that you provide positive pressure ventilation before the 1 minute, which is the 60 seconds elapse. So what are the golden action plans that you can do within, especially in the first minute at birth? You're going to receive this preterm baby in a plastic wrap. So the NRP recommends the food grade Wilveras. That's the word we will cover that with. The see-through polythene plastic bags that we have, we can use them to keep the babies warm. So we can have them in our delivery rooms so that they are readily available to be wrapped in the babies. Then you need to immediately, what you can do and cannot be postponed is to provide delivery CPAP. I emphasize delivery CPAP because studies have shown that CPAP is effectively reducing chances of having severe respiratory distress or the baby needing ventilation support. So the earlier we start CPAP in the delivery room, the better. And also having to transport the baby to NICU in a safe and warm incubator. And then also you can provide vitamin K immediately. That cannot wait. What can wait is maybe the eye care, the cord care, the vaccinations that can be given later when the baby is in the NICU. So we talked about the rapid questions that you need to ask and also assess at birth. If the baby is a preterm, you need to bring the baby to the warmer and perform the initial steps from there. Check if the baby has a good muscle tone, especially these ones will require urgent interventions. Then also check if the baby is breathing or crying. However, for a baby who is having a poor muscle tone at birth, you need to still go through the initial steps. You don't hurriedly provide PPV. You first perform the initial steps and then you provide PPV if the baby has not responded to the initial steps. Next slide. So these pictures are showing us the different babies. So the first baby on the left shows a baby who is having a good muscle tone. The baby on the left is showing us the baby who has a poor muscle tone, who definitely needs immediate resuscitation. Next. So for delayed cord clamping, what studies suggest is NRP suggests 30 to 60 seconds, especially for the most vigorous term. And while you're providing delayed cord clamping, you're supposed to ensure that you're performing the initial steps of resuscitation while you're waiting for the 30 to 60 seconds to elapse. So ensure that you do not delay to provide the initial care for these babies while you're providing delayed cord clamping, because it has many benefits, especially for the preterm babies. Next. So some of the potential benefits is delayed cord clamping decreases the chance of needing medication to support blood pressure, especially after birth for preterm babies, and they may require fewer blood transfusions. And also studies have shown that delayed cord clamping improves survival. However, you have to note that the babies might need to go under phototherapy because of hyperbilirubinemia, because of increased blood volume. So what we need to also understand about APGA timing, you start APGA timing when the last fetal part emerges from the mother. We've had instances where the baby's head is out and someone starts the APGA timer. No, the APGA timing starts when the whole baby is out, is born already, and also when not the cord is cut. So once you start the APGA time, your score at 1 minute means the baby has lived for 60 seconds, not immediately at birth. So you have the 60 seconds to provide all those actions, interventions for the baby. So your APGA score should be at 1 minute, not at 0 minutes, at 1 minute after birth, and then you repeat at 5 minutes until the baby is stable. The APGA score can also be scored up to 20 minutes. So the components of the APGA is A for appearance, you assess the baby's color, you assess, then P is for pulse, you assess the baby's heart rate by using a stethoscope and listening to the heart rate for the first 6 seconds, and then you multiply by 10. Then G is for grimace, which is response to stimulation. When you touch the baby, do they move their extremities? Then A is for activity. How is the baby's muscle tone? Are they flexed or they are just having a poor muscle tone? Then R is for respiration. And make sure that you know the normal respiratory rate for the babies, which is 40 to 60. So if the baby is having difficulty in breathing, labored breathing, so this also needs to be assessed. So this chart shows us the different assessments that you can do. So for A, which is the appearance, we said it's the skin color. For a baby who is bluish, might score 0. Then a baby who has just bluish extremities, the hands and the legs, can score 1. And then the baby who is pink scores 2. For pulse, if when there is no absent, when the pulse is absent, then the baby scores a 0. When the pulse rate is below 100, the baby scores 1. And when you take the pulse and it's above 100, the baby scores 2. Then the activity, if there's no movement at all of this baby, it's 0. When the legs and the hands are just flexed but no movement, then it's 1. If the baby is actively moving their extremities, moving their body, then you give them a 2. Respiration, if there's no respiration rate, if the baby is not breathing at all, you score them 0. If they have a weak or slow or irregular respiration, you give them a 1. And the baby, if the baby is vigorously crying, you score them 2. So you add up your totals, and the whole total should be out of 10. And that can guide you to see which baby is severely depressed or baby who needs further attention. So this picture just shows us how we call peripheral cyanosis and central cyanosis. So central cyanosis, the baby has the trunk and the head and the mucous membrane are bluish. Next. So APGA score, we have to know that it's not used to determine the need for resuscitation. So that baby dictates the need for resuscitation. Next. So the prediction of the APGA timing, a low 1 minute APGA score does not correlate with the infant's future outcome. So we usually use the 5 minute APGA score to consider to have immediate interventions, or a score of 5 and 6 and below needs immediate intervention and can increase the baby's risk of neurological dysfunction. So when you're recording this APGA, a 5 minute APGA is very important to document, to ensure that the baby is, to ensure that you provide the baby with essential and effective resuscitation. Next. So what are the initial steps of resuscitation? You are going to provide warmth. During preparation, you've already switched on your radiant warmer. You've already prepared all the equipment that you're going to use for providing warmth. Then dry, stimulate, position the head, neck, and open the airway and ensure you clear secretions from the airway if needed. There's current guidelines do not recommend clearing secretions from every baby. You only clear what you're able to see. So in providing the warmth, we've said that preterm babies are received in plastic bags because they are able to reduce the heat loss. And also, if you anticipate the baby is going to remain under a radiant warmer for a longer period of time, you're going to need the temperature sensor attached to the baby's skin so that you're able to monitor that baby's temperature very well. And also during the resuscitation and stabilization of this baby, you need to maintain their temperature at 36.5 to 37.5. Please avoid overheating these babies. So this picture shows the polythene bag that is used to maintain the warmth for the preterm babies. You see the baby can even be resuscitated while they are in the polythene bag. Next. As you can see, this is a baby that was attended to in last month, and their temperature remained normal despite vigorous resuscitation. This baby underwent positive pressure ventilation, but they maintained their temperature because of the NeoHelp, one of the plastic bags that we use currently at Mulago Specialized Women and Neonatal Hospital. So during the initial steps of drying, the preterm babies no need to be dried. However, we can only dry the face to remove any maternal fluids on the face and clear the airway as well. So we can only dry the face, but the body needs to, you don't dry the baby if you're going to put them in the polythene bag. Also to emphasize is you can still weigh the baby later when the baby has stabilized while they are in the polythene bag. So this specific NeoHelp has the weight that it comes with. So when you weigh the baby with it, you just subtract the weight of the polythene bag. But for the food grade plastic bags that we have, they don't weigh. Their weight is definitely zero. So you're going to just weigh the baby with a Cavera and take it as it is. Next. So stimulating, please, we don't recommend shaking the baby. Ensure that you stimulate the baby's back and the torso. Avoid vigorous stimulation because this can cause injury, especially to the baby's brain. Then positioning the airway. Babies' necks are very soft and long, so you need to ensure that you maintain a sleeping position by providing a small cushion or a towel under the shoulders, which we are going to see in the next slide. As you can see, the shoulder pad provides the babies to maintain a sleeping position, which enables the airway to remain open. Airway, for suctioning the airway, you gently suction with a bulb syringe or the penguin sucker. If the baby has a lot of secretion, turn the baby to the side and they usually collect in the cheek and you're able to suction very well. So do not suction what you're not seeing or avoid deep suctioning. Okay, so next. So we have a 30-second video of the initial steps that you're able to watch and appreciate how you'll be able to provide the initial steps of resuscitation, especially following the steps and very fast. So in the steps, you're going to see how you're able to receive the baby and dry the baby, remove the wet linen, and if the baby remains apneic despite the initial steps, you're able to provide positive pressure ventilation even within the first 60 seconds.
The baby is born and a rapid evaluation is performed. This baby is term, but has poor tone and does not breathe or cry at birth. The baby arrives at the warmer limp and apneic. Her mouth and nose are suctioned in anticipation of positive pressure ventilation. She's dried, the wet linen is removed, and her head is positioned to open her airway. Despite these initial steps, she remains apneic. PPV begins immediately within the first 60 seconds after birth.
So next. Okay. So, go back. So if the baby is breathing, so when the baby has received the initial steps, but they are not responding, they are not breathing, you still go and evaluate. So if the baby is breathing and the heart rate is at least 100%, 100 beats per minute, but the baby appears cyanotic, ensure that you put the pulse oximeter on the baby to ensure that you are able to regulate the targeted oxygen. Next. So use a pulse oximeter on the baby, especially when you anticipate resuscitation, to confirm especially your perception of the persistent central cyanosis, to guide you to either give supplemental oxygen, but for our case, for preterm babies, they need CPAP, or if you need positive pressure ventilation. So this is a table that shows you the targeted oxygen saturation after birth. Next. It's very important to also understand how and when you administer CPAP. So if the baby is breathing after the initial steps of resuscitation, but has a heart rate of at least 100 beats per minute, but has labored respirations or labored breathing. Labored breathing is when the chest muscle goes inside. So the baby needs to be administered on CPAP. So provide the CPAP which is already prepared for you in the delivery room as early as possible so that you reduce the need for intubation or mechanical ventilation later. Ensure that you do not administer CPAP to babies who are not spontaneously breathing. So these are the studies that show that they've done that show the effectiveness of providing early CPAP in the delivery room compared to longer delays in providing CPAP. Next. So these are different equipment that you can use to provide CPAP. You can use a TPIS, a resuscitator. You can use a bubble CPAP to provide CPAP, bubble CPAP. Try to do this first. So for a baby who remains apneic, who is not breathing, or a baby who is gasping, gasping is taken to be apnea or ineffective breathing. So all the babies who are gasping or who have a heart rate below 100 beats per minute, they need to be started or initiated on positive pressure ventilation within the first 60 seconds. Next. So these are different devices that you can use to provide positive pressure ventilation. Next, try to be. So ensure that you have selected the right mask on the baby. So there is an anatomical face mask or the round mask. So you ensure you've selected the right mask, should fit the nose and the chin and the mouth. So positive pressure ventilation is indicated for a baby who is not breathing, a baby who is gasping, or a baby whose heart rate remains below 100 beats per minute despite the initial steps of resuscitation. So it's recommended that for preterm babies, you start with an oxygen concentration of 21 to 30% blended oxygen. So that is definitely room air. So we've seen that even with room air, without oxygen, we are able to provide positive pressure ventilation. So we shouldn't say that we do not have oxygen to provide positive pressure ventilation, and just have an arm bag and start positive pressure ventilation within the first 60 seconds. Okay, we've already talked about this, the pressures that you're supposed to use in providing PPV. Next. And you aim at giving 40 to 60 breaths per minute. You can go through the rhythm of breathe, 2, 3, breathe, 2, 3, so that you maintain the rhythm to provide the correct rate of breaths, which is 40 to 60 breaths per minute. So we are going to watch this 2-minute video to show us how to administer positive pressure ventilation to a preterm baby. So in this video, we are going to see how effective positive pressure ventilation is provided to a preterm baby who has remained apneic or is not breathing and needs effective positive pressure ventilations to inflate the lungs.
During your equipment check, you anticipated the correct size mask and prepared the PPV device for use. The mask should rest on the chin and cover the mouth and nose, but not the eyes. Position the baby's head in sniffing position. A shoulder roll may be helpful to lift the shoulders. Cup the chin in the mask. Bring the mask up and over the mouth and nose. Encircle the rim with your thumb and index finger. Your other fingers are under the bony angle of the jaw. Do not push the mask down on the face. Lift the jaw up toward the mask. Put gentle pressure on the rim of the mask to form a seal and hold the head in sniffing position. Don't rest your hand on the baby's eyes or compress the baby's neck. Now that you've watched a slow demonstration of mask placement, watch in real time. Now you're ready to assess the effectiveness of your PPV. People often get nervous and ventilate too fast, so help each other maintain the correct rate. Breaths are given at a rate of 40 to 60 breaths per minute. Use a waltzing rhythm. Breathe 2, 3, breathe 2, 3, breathe 2, 3, breathe 2, 3. Start with a positive inspiratory pressure of 20 to 25 centimeters water. Full-term babies may require up to 30 to 40 centimeters water for their first few breaths to inflate the lungs, then need less pressure to maintain chest movement. You should see a gentle rise and fall of the chest, not very deep breaths. If you cannot maintain a good seal, try the two-hand technique. Hold the mask against the face with your thumbs and first fingers. Place the other 3 fingers of each hand under the bony angle of the jaw and lift the jaw forward. Hold the head in sniffing position. An assistant gives the breath, and a third person is needed to monitor heart rate and chest movement.
Okay, thank you for watching that video. Hope you learned how to provide effective pressure ventilations to a baby who has remained apneic at birth. We also need to, it's very important to also have a stethoscope readily available so that you're able to assess the heart rate. So to know that you're giving effective ventilation is you're going to have a rising heart rate. So if your the baby's heart rate is not rising, that means your positive pressure ventilation is not effective. Also, we have to ensure that for the babies who are undergoing positive pressure ventilation and continuous CPAP, they need to be inserted an orogastric tube. Orogastric tube is preferred to nasal gastric tube because babies predominantly nasal breathers. So if you're going to put the NG tube, which is the nasogastric tube, you're going to reduce on the airway, which we don't want at this moment. So the orogastric tube is mostly recommended, so you're able to maintain an open airway. So this shows us how you're able to assess for the rising of the heart rate of the baby. Next. They need to go through. Go through. So for a baby, in case your baby is not responding to the positive pressure ventilation, these are the corrective steps which we use the mnemonic as Mr. Sofa. So adjust the mask. Maybe your mask is very big. You need to get the right size of the mask, or reposition the airway. Try to ensure that the sniffing position is maintained. Then check if there are some secretions which are blocking the airway. Open the mouth when you're providing the PPV. Then go through the pressure. We have started with the lowest pressure of 20 to 25, so you can increase in bits of 5 to 10 up to the maximum of 40. Then in case the baby is not responding, that's when you provide an alternative airway, in this case, which can be the endotracheal tube, which we are not going to see at for now. So if the baby is breathing spontaneously and the heart rate is at least 100 beats per minute, but the baby has labored breathing, then you put this baby on the CPAP while in the delivery room. Next. So newborn, like what I would emphasize for you all health workers who are attending to every delivery in your respective hospitals, what message I can give you now is to ensure that you plan and prepare for every delivery in your hospital. Ensure maintain to ventilate and inflate the baby's lungs in the first 60 seconds. So ensure that you assess your heart rate to ensure that it is rising, especially when you're giving positive pressure ventilation. So what you need to know is if your heart rate is not rising, if it remains below 100, that means your ventilation is not effective. So ensure that you have a good chest rise to be able to proceed to the next steps, and use the pulse oximeter to guide you on how you can change the oxygen requirements for the baby. So thank you. We are now done for the first initial steps. I mean the NRP essential package for the preterm baby at birth. We can now listen to the next presenter. Thank you.
Thank you so much, Ms. Claire, for that whole structured approach to neonatal resuscitation. It has been a lengthy one, and I guess we've all got the actionable takeaway points. At this point, I will invite Dr. Anita to take us through the post-resuscitation care.
Good afternoon, everyone. The resuscitation, neonatal resuscitation is something we cannot really learn in a very short time. So the team has tried to really package it in a very short time. That's why you see it needs not less than 2 days to really master and learn this. So hope we can have more and more sessions to be able to understand and master the skill. We are continuing to lose so many of our babies. And this is a critical and essential skill that every health worker needs to have. So resuscitation is key, and I think will continue to be emphasized. And every health worker should take the initiative, should be proactive to make sure they have their skills and keep their skills up to date. So I'm going to quickly look at post-resuscitation care. So what happens when you've done a very good resuscitation? What happens next to the baby? So oftentimes we tend to put so much emphasis on resuscitation, but we forget what happens beyond. Babies are pulled out. Maybe they had an ABGA score of 3 at 1 minute. It has improved to 7. If we don't take the next steps correctly, you can actually still have that baby deteriorate. So your efforts can go to waste if you don't give the best care post-resuscitation. So I'm going to package this into 6 core elements that we shall look at. This comes from it uses the acronym STABLE from the STABLE guidelines for neonates. On the screen, you can see what STABLE stands for. S, we look at sugar, temperature, airway, breathing, lab test, and emotional support. And you shall split them one by one as you go on. So after doing your resuscitation, remember this baby needs energy. Because one, maybe they are struggling to breathe, they are struggling to maintain their warmth, the temperature, but they need energy. What is going to be their source of energy? So we need to make sure that you check their blood glucose levels. We can use the glucometer. We must have a glucometer to check the baby's blood sugar levels. And you can see the normal range for newborns is from 2.6 millimoles to 8. So babies who are at 2.6 or below, we need to actually initiate steps in managing the baby, because hypoglycemia can actually kill the baby if we don't act. Remember, they have a high metabolism, the baby is probably struggling, they've come through a stressful period, so they actually need the sugar, they need the glucose. So we should make sure we maintain their blood sugar in the normal range. So a baby who has required resuscitation up to chest compressions, maybe beyond the normal stimulation, beyond just stimulation, you should make sure there's an IV line put in place. At least at the end, when your baby has started breathing, part of the team should make sure the baby has an IV line. And in that, we can give the baby 10% dextrose at a rate of about 2 ml per kg. That is just a bolus dose. But remember, they need maintenance fluids, which you calculate according to the gestation ages and the weight of the babies. Extreme preterm babies are a special category, those less than 1 kg or less than 1,000 grams. Usually we give them 5% dextrose because their system, they may not be able to tolerate very high concentrations of glucose beyond the 5%. But this will also depend on what their random blood sugar is. So that is the first core element. The next one is temperature. Maybe before temperature, a little bit about the sugar. So hypoglycemia or low blood sugar can actually cause neurological damage to the neonates. These are very fragile brains which are still growing, and a dip in the blood sugar can actually give your baby a poor quality of life later on, even if they survive. So the next block is the temperature, like we had from the previous presenters. Temperature control is very important. Like we see in the picture there, I think you saw that picture earlier. This is a preterm baby who was resuscitated, is connected to CPAP, is in a polythene, but also is in a transport warmer blanket. And you can see the baby's temperature reads 36.7. We want to keep our babies in a normal temperature because one thing you need to take from this is that hypothermia, any temperature below 36.5 and further, the moment they dip into hypothermia, their risk of death increases threefold. So even if they survive everything else, just an initial exposure to a low temperature is going to increase the odds of dying. And we don't want that. So we need to make sure temperature is key and is very important because so many body systems depend on a normal environment, normal temperature for them to function. That is the second block. We shall look at the third block, A, the airway. We saw during resuscitation how the baby should be positioned, maybe with the head neutral, but the baby put in a sniffing position overall that avoid hyperextension of the neck or excessive flexion of the baby's neck. It was because of the nature of the airway, when you do hyperextension or flexion of the neck, you're actually going to block the airway. So you need to position them in the very right position to be able to keep the airway open. And suction, like we had, should only be for visible secretions. What is recommended now, you can see the old bulb syringe there in the picture, but we are saying that may not be safe. So we are now recommending the using the penguin sucker that you have looked at, the clear penguin sucker, which is easy to clean, can be opened, can be cleaned, and you're able to see whether there's anything inside because you're able to open it and wash it well. So the old bulb syringes are not recommended because keeping them clean is very difficult. So we need to listen also, we need to listen for any stridor because after resuscitation, some babies may get edema of the airway. Some babies may have airway blockage, maybe from some congenital abnormalities. So we need to check whether they have airway obstruction, which may need immediate intervention. And of course, the alternative airway for centers which do advanced care, advanced support, is the endotracheal tube intubation of the baby. So that's an alternative airway when the baby's airway has failed, for babies who can access advanced care. So the next block is breathing. So we looked at the sugar, the temperature, the airway, and quickly we look at the breathing. Remember, some of these were considered, they were actually intervened on during resuscitation, but how do we maintain the baby breathing? And if they are breathing, are they breathing adequately? So the main thing in post-resuscitation is to assess the adequacy of breathing. So we heard from Sister Claire's presentation, a baby who is not breathing, if the baby gets apnea or they've stopped breathing, CPAP will not help them. If they have stopped breathing, we are going to need PPV. You need to initiate PPV again. But if the baby is breathing, you need to look at adequacy. Are they breathing with distress? Are they using accessory muscles? They have chest indrawing, they are struggling. Then you need to initiate CPAP. Put the baby on CPAP. Like you see that preterm baby in the picture is on CPAP. We do provide free flow oxygen, especially for the term babies. But recommended is all preterm babies must be initiated on CPAP. So we must have a CPAP, a form of CPAP in the delivery room for the preterm babies. Key to note, do not wait until they have developed distress to put them on CPAP. If we can remember, as we had in the case presentation that we had earlier, this was a preterm who was delivered and put on free flow oxygen, CPAP initiated later, which could have come maybe an hour or so later. So this, by the time the baby has been on free flow for about an hour, most of their alveoli are going to collapse because they lack surfactant. And the CPAP is going to give us that positive end expiratory pressure that's going to keep the alveoli open. So if you don't initiate them on CPAP immediately, the alveoli will collapse and it's going to be much more difficult to open them up. So most of them will end up in atelectasis or lung collapse. So if you intervene early, you can save them. If you bring on the intervention later, it may not make a difference. Key points, put them on all preterms, CPAP at birth, and immediately after they are born after the initial assessment and resuscitation, start your CPAP immediately. And then they can be weaned off as they progress to the neonatal unit later if they are stable. So the next block is the lab tests. So after you've resuscitated your baby and you've done everything, you may notice your baby may be anemic, in which case you need a quick blood sample, maybe blood grouping, or you need a CBC, because the baby may need a blood transfusion. So this should not wait until they go to the neonatal unit. Blood sample can be taken off, rushed to the lab, even as the baby is awaiting transfer. So this will help us save time. The next block, the E, is emotional support. This is often overlooked and yet so important. So most times we do so much, but we don't keep parents or caretakers in the loop. And this causes a lot of anxiety, a lot of questions, miscommunication, and dissatisfaction. So if you want to, you need to always keep parents in the loop, because remember, not all resuscitations will be successful. Even if they are successful, some of the babies will end up with long-term complications. So always keep parents in the loop of, what happened, what are you doing, what are you planning to do, and what may happen to the baby. So holistic management is key. Let us always consider the baby not as an isolated unit, but as part of a family that we need to manage. Those are the main blocks of post-resuscitation care, which I've summarized using the stable guidelines, which you can quickly access. But after you've stabilized your baby, indeed, so this baby needs to transition. We are assuming we are still in the delivery room because they've been resuscitated. We have a post-resuscitation care. So it's for some centers, the neonatal unit may be just across the door. But for some other places, let's say this baby is born in a health center 4 or 3 and needs to be transported to the next level of care. Even in some hospitals, you find the neonatal unit is on a different floor from the delivery room. So that is also transportation. So transportation can be intra-hospital or inter-facility across. So we need to prepare this baby for transportation if they need to move. Even if the baby is moving across the door from let's say the theater or the labor ward to the neonatal unit, they must be transported in accordance with the stable guidelines. You must ensure everything. That baby must be warm. The baby must be well swaddled, must be warm. The airway should be clear. Like you can see that baby is well swaddled, is on CPAP, is on a warm bag. That is an electric blanket. And the baby is ready to be moved. And they must be transported on CPAP. Because remember we said, we initiate CPAP to keep the alveoli open. So if you remove it and take the baby to the neonatal unit, just even those 2-3 minutes that you're going to move the baby, they're already going to go into collapse because you need to maintain, I should say, that chain of breathing. So you should not cut it by removing the baby and you run to the neonatal unit, which is a very bad practice in many of our places that we need to unlearn today. We must stop running with babies who are decompensated, babies who are not stable. First, stabilize the baby and take them to the next level of care. So when we are transporting the baby, I'll try to go through this very fast. There's some core principles which use the acronym also ACCEPT that we look at. So you need to assess, and go to the next. We need to assess the baby, what is needed, what kind of care, are we able to give the care where we are, who is in charge of the transport, has communication been made? And communication does not only mean pre-referral if the baby is crossing to another facility. Even within the same facility, if you're in the labor ward, you must communicate to the neonatal unit that we are bringing you a baby, they should be prepared. So communication can be whether within the hospital or across if you're referring the baby outside. Evaluation should be done, make sure the baby is fit for transportation and of course preparation. And the mode of transport should be safe. We are advocating for safe transportation. We need that designated transport for our neonates because they cannot be transported on adult coaches. We need to have neonatal ambulances. Okay. So these are some of the means. Next slide. You saw in the picture before, in utero transfer, so in the case that we had, the case that was presented, probably this is where in utero transfer should have happened if there was chance to do it. Because this was a preterm baby remote from term, who probably couldn't be managed at the facility. And probably the safest transfer would have been to transfer the mother where she could deliver from. So this is at a center where there's advanced care for the preterm. So in utero transfer is the safest and best mode. If you anticipate that this baby will not be, you do not have the facilities to care for the baby, then better you transfer the mother to deliver where they can be cared. But just like we see emergencies happen, even like in that case, mothers come in labor and they deliver. So when the baby has been born, then you must think of how to safely transport them. So those are some of the indications for transport, which I've already talked to. Next. I've already talked about that, so we can go to the next bit. These are some of the problems you need to anticipate and prepare. You plan how to manage. So during transport, your baby may stop breathing. The temperatures can drop, sugar can go down, the blood pressure. So the babies are most unstable during transportation, and that's why we emphasize pre-transport stabilization. Do not rush to transport a baby. We have had so many scenarios of death on arrival. That means something went wrong. Baby was not ready or the transportation was not proper. So maybe this baby would have survived if they had taken time to stabilize them at the point where they were. So death on arrival is something we need to eliminate from our settings. So we need to stabilize these babies before we move them from place to place. Those are some of the requirements from transport. I think I've alluded to all of them. Ensure baby is stable, communication has been done, and consent from parents, of course. You must not take the baby if there's no consent. Remember, sometimes the mother may even still be in theater, but the baby needs to go to the next level of care. So you must look for the next of kin. Those are some of the equipment requirements. So whatever we required for resuscitation, remember we shall also need during transportation, and I will not go back to some of this. Just remember we need to maintain warmth and the airway and everything else. Next. We talked about this already, that a baby should be stable, going by the acronym, before, during, and after transportation. Those are some of the medications you need to always have on hand when you're transporting the baby, because you're likely to need at least have adrenaline, have some dextrose, have saline, have anticonvulsants, because these babies do convulse sometimes. And the medicines should be transported already pre-filled syringes, maybe pre-measured to the baby's weight for quick administration. Those are just some ways of transporting babies. Even though we may not have transport incubators, we can do skin to skin. Like you see, the baby can be transported skin to skin. That alone can save the baby. Remember, hypothermia alone increases the odds of death threefold. So find a way to keep the baby warm. Is it the polythene? Is it skin to skin? Is it the transport blanket? Is it the transport incubator? So there are different modes in which you can transport these babies. Next, those are just non-electric transport blankets, which we can use, the Embrace warmer or the Womilu. They use heat-activated gel packs, which are prepared before transportation. And once it's activated, it remains warm for 4 hours, so the baby is able to reach the next level of care. That is a transport incubator, which should be ideal, but for our low resource settings, where we know most of our places, we may not afford that, but that's where we need to aim to achieve. That would be the safest, especially for our preterm babies. So during transportation, I may not repeat this. We said keep check on your baby, make sure they are not apneic, the airway is open, they are breathing. Is their blood pressure okay? Are they pink? Are they saturating well? So keep the baby in check. Next. So always remember, if you're transferring a baby, if the mother is able to move along, it's always best you transfer the mother and the baby together. But like I said, sometimes the mother is not yet stabilized, yet the baby needs to move to the next level of care. So if they can move together, well and good. That would be the best. So when the baby reaches the next level of care, be sure to hand over, to make a complete transfer. So it should be from, and give complete information to the health worker receiving the baby. And if possible, leave a contact, because they may need more about the delivery information for the baby. We should always be cautious when we are transporting babies to avoid the shaken baby syndrome, because their brains are still maturing, and they can easily get concussion or the shaken baby syndrome. So they should be well secured during transportation. So this is the last slide, something we need to all think about, the ethics and end-of-life care. So when we talk about resuscitation, we must talk about end-of-life care. When do you call it quits? When do you say enough is enough? When do you stop resuscitation? So what if it's not yielding results? What are you going to do? So we must know that all the ethical principles still apply, and we must uphold them. But remember, whatever decision you make should be what is best for the newborn. And remember, the parents are the next surrogate decision makers for this baby, and they must share in decision making where you plan to terminate resuscitation or not even to resuscitate at all. Remember, compassionate, culturally sensitive palliative care should be provided. So you must make sure you provide comfort even when death is imminent and you can't stop it. Thank you so much.
Thank you so much, Dr. Anita, for that expert knowledge and perspective on neonatal resuscitation. I hope the audience has been able to learn and unlearn on some of the key areas concerning neonatal resuscitation. At this point, I will invite the audience to raise their questions, any concerns, comments. You can raise up your hand. If you have any question, any addition, if there is none, post-test questions are going to be launched on your screen. Kindly attempt them. You are mute. We continue. Okay. Okay. I want to thank you all for tuning into this session. You've been an amazing audience. Thank you all for your thoughtful contributions. For those that came in, I will invite the experts to give in their closing remarks, take-home message in a nutshell. We have someone. Yes, Mr. Emmanuel.
Okay, good afternoon.
Good afternoon.
Good afternoon. I'm Emmanuel from Benue State in Nigeria. My question is concerning some practices I have seen done during neonatal resuscitation. Sometimes the baby is turned upside down, holding the leg, and then being massaged on the back. I wanted to understand what are the implications of such practices. And then again, I've seen people put something like spirit
put a little spirit and then put on the nose of the baby. And then in some cases, talking about the cleaning of the baby for 10 babies, do we need to, what is the role? I've seen people use olive oil to clean the whole of the body of the baby. Are these things having any form of implications, or are they harmless practices in our society? I just wanted to know, what are your take on that?
Let's have Dr. Umal Senkubuge. Kindly unmute and voice out your question.
Thank you, Dr. Anita, for the wonderful presentation, for the expert overview, and Sister Claire. I would really love to emphasize or ask that, since we have different practitioners on this course, mostly pre-hospital care people, they have the resources and they are in direct contact with these mothers. And in a patient like this, the reason this patient deteriorated, if this patient happened in the field, the guys have their resources to resuscitate to the level of care, at least that Sister Claire talked about. If we could focus more on that as well, to try and decipher this information to a pre-hospital or out of hospital setting, that would really be great and reduce some of the fatalities that we get to see in the ED. Thank you.
Thank you for that. Let's have one last one. That is Mr. Tommy. Tommy, yeah. Kindly unmute.
Yes, good evening. I am Oyaro Tony Peter. I'm calling from Navy. I'm a medical officer attached to PID ward and NICU. During the process of resuscitation, the presenter made mention that there is need to put a shoulder pad. And yet, during resuscitation, baby is supposed to be in a neutral position. So I really wanted to know, is there any particular advantage or importance of the shoulder pad, or it is just a cloth underneath the baby to provide warmth, but baby should be in a neutral position? I needed more clarification on that. Thank you.
Okay, our experts will attempt to do this.
Thank you so much. I'll respond to the first question, and Sister Claire will respond to the one about the positioning and the shoulder pad. So thank you, Mr. Emmanuel, for those comments or questions about some of the cultural, should I say cultural practices and others. So to start with, the practice of holding a baby by the legs upside down, sometimes massaging the back, old practice, even slapping the baby's back. So, these are some of the practices that we are saying now are harmful to the babies. Because just by turning that baby upside down, you're going to cause a sudden increase in blood flow to the brain, leading to actually intraventricular hemorrhage or intracranial hemorrhage, especially for the preterm babies. So these are some of the practices we actually need to stop, to discourage, and to make sure no one still practices. Like we had earlier, these babies should be handled in a very gentle way because they are very delicate and prone to complications just from our handling as well. And the practice of putting whether spirit or alcohol, just to make the baby probably wake up, these are actually wrong. They are not correct practices. Let's stick to what is safe, evidence-based, and proved to improve outcomes for the babies. I know some of these may be cultural practices like smearing olive oil or other to the babies, but it's important that we help our caregivers understand. They need to understand that some of these practices can actually be harmful. Some may be harmless, maybe like putting oil on the baby, but some of these like putting the spirit or tying the baby, so these we should discourage because they've been shown to be more harmful and not beneficial to the babies. Let's Sister Claire can respond maybe about what's the benefit of that shoulder pad. She mentioned especially for the preterm babies.
So thank you for that question. So we need a shoulder pad, which is a small soft bed sheet, which is folded and put under the shoulders of the baby to maintain the sleeping position. So this position is able to maintain an open airway for the babies to enable air entry into the lungs very effectively. So usually sometimes babies, especially preterm babies, have a big occiput. So when you lie the baby on the back, it might affect the airway. It might cause air obstruction. So putting the shoulder pad enables the chest to be slightly raised so that you maintain an open airway. So it should be under the shoulder, just a small folded bed sheet is enough to provide and maintain that neutral position or sleeping position that we need to maintain an open airway. I hope I've answered your question well.
Thank you for that. Dr. Palmer, if you have any comments that you would want to, 1 minute, in 1 minute.
Thank you very much, everybody, for attending the session. Once again, this is Dr. Palmer Chen. I have basically been responding to the chat questions, and just my final remarks, basing on the questions that has been coming in. There is still need to do a lot on the CPAP, the continuous positive airway pressure. I know all of us on the call we are not at the same level, so there were a lot of questions coming in about the indication, the mechanism of action of the CPAP, and as well as how to make the improvised CPAP. So I think maybe we shall plan for that so that our audience can understand better on the use of the CPAP machine. Otherwise, thank you very much.
Okay. Thank you once again. My name is Albert Okanya. I would like to appreciate everyone who has taken part in this discussion. I believe at least something will change about how each one of us handles these newborns, especially the preterms. They are delicate, so appropriate handling and timely interventions are very crucial in making successful results, like the outcomes being successful. I still agree with Doctor on the fact that much as we have learned, I believe much today, it's not entirely enough to have all of us practice accordingly and according to the new rules. I've had a lot of my colleagues from Guru Regional Referral Hospital reporting to me that they have not been able to attend. They were trying the link and they were not able to get in. I couldn't ascertain why, because that's why I made an attempt to join myself almost at the last minute, but I was successful. So I think it was either issues to do with network or something else. So I believe more of this is needed for everyone to get on deck with the new things. Then, according to our polls on the post test, maybe I can comment on those first two numbers that are visible there. We can see majorly the first question, everyone was debating between preparation for resuscitation and stimulation of the baby. So the question was asking us on neonatal resuscitation. So meaning you had already prepared in advance. It's like asking you, when you're to get a job, what is the first, okay, thank you, let me try to speed up. What is the first step? You're going to look, you're in a process of looking for a job now, not school. So we had prepared already. So our first step is going to be drying this baby and commencing the stimulation, but not preparing. Then on the second one, our golden minute is the time we start the effective ventilation. Otherwise, due to the interest of time, I kindly beg to end here. Thank you so much.
Thank you all who got a chance or who got time to join in the call and learn. I hope you've learned a lot today and unlearned the bad behaviors that we usually do as health workers in the delivery ward. So we need, what I would encourage you to go with today is to make sure that for every birth and spate resuscitation, so prepare and ensure that you ask all the antenatal, all the risks so that you're able to know and provide effective resuscitation to any baby that you handle. Thank you.
Thank you everyone for making time to attend this very important presentation. Something to go home with. One, like everyone has said, always be prepared. Number two, let's learn to refresh our skills every often, because we need to do it right if we are to reduce the neonatal mortality in this country. Number three, post-resuscitation care is as important as the actual resuscitation itself, because actually all your efforts can be undone if you don't give the baby the appropriate post-resuscitation care. Thank you so much.
Yeah, yeah, thank you so much, everyone, our online team. There's a lot that has been said, but let's take all the things at heart and we practice more on neonatal resuscitation. And also there is need at health facility level, the different departments to follow this standardized protocol of neonatal resuscitation. We want to be in a setting where the way the anesthesia team resuscitates their babies or the maternity, obstetrics, and pediatric team resuscitate is the same. Yeah, thank you so much.
At this particular time, I would kindly request each one of you to switch on your videos. Switch on your videos, and thank you again for tuning in, for sparing time of your busy schedules. Kindly switch on your video. At least we are now sure that we've not been talking to ourselves.